welcome back, those of you from yesterday, and a first welcome to those of you who are joining us today for the first time. It is my pleasure to introduce Dr. Tiffany Washington, who is the John A. Hartford Social Work Scholar at the University of Georgia's Graduate School of Social Work. Her full bio is available via link in the packet of materials that you received upon registration. Dr. Washington's presentation is going to focus on using the expert panel framework specifically. And just before I transition, relinquish the Zoom screen to Dr. Washington, I did want to pause just for a moment and give a big shout out to the Health Foundation of Western and Central New York. Dr. Washington's study is being funded by the Health Foundation and is being conducted in the Foundation's 17 county service area in Western and Central New York. It's particularly important for me to share with you that the funds that are available for this research were provided by the Foundation specifically to help ARCH advance the respite research agenda. The funds were awarded to Dr. Washington, who is a member of ARCH's Respite Research Consortium, after her proposal was reviewed and accepted by the Foundation. In addition to the general recognition of the Health Foundation, I want to recognize specifically Dr. Diane Euler, who's the Vice President for Programs, and who worked closely with me and Jill to make this funding opportunity a reality. Also, Mr. Ken Jenowick, who is a Program Officer at the Foundation, a Program Officer for Caregiving. And also, well, I don't think she's in attendance today, a special thank you to the leadership of the Health Foundation, and that's Dr. Nora O'Brien-Surik. As president of the Health Foundation of Western Central New York, obviously she oversees all of their operations. And she took time last year to attend the ARCH National Conference in Buffalo and gave strong support to ARCH, not just for the support of the Lifespan Respite program, but also to the support of ARCH's initiative to establish the evidence base for respite and to conduct this essential research. So with that, let me hand the torch to Dr. Washington and thank her for her willingness to appear today and share with us her efforts.
Well, no, thank you. I'm so willing to be here and share my efforts today. So thanks again, Dr. Kirk, for that introduction and for setting me up to discuss this work in progress. Typically, I wouldn't present ahead of definitive findings, but what I'm loving about this summit is that it's giving us the space to discuss these wonderful opportunities in respite research and how we've been tackling some of the common design and methodological challenges I'm sure that you discussed on yesterday. I wasn't able to attend, but I'm sure that you've been having those wonderful discussions, and I look forward to continuing those discussions in this presentation. I too want to just express my gratitude to the Health Foundation for Western and Central New York. Thank you so much to Diane Euler, to Ken Jenowick, and all of the others there for being so supportive of what we've been doing through this work. I also want to say thank you to, of course, ARCH, the National Respite Network and Resource Center, for brokering this relationship. We've had some great consultants for this project, Drs. Cheryl Zimmerman and Thomas Caprio at the University of North Carolina, at Chapel Hill and the University of Rochester, respectively. And of course, I have to give a shout out to the wonderful student workers at the our Health and Aging Research Lab at the University of Georgia, who have just really enjoyed this project and have really enjoyed opportunities to talk to caregivers to understand their experiences with respite. And one last thing I'll say, Dr. Kirk mentioned the conference last year in Buffalo, New York. Some of you heard me present there. You know that my sort of entry point into this respite research has been with a program that I designed and have pilot tested, and now I'm working to scale a respite project that involves graduate students, so training the future workforce on filling some of the gaps in delivering respite care. And so at the end of this presentation, I'll certainly talk about how this work will inform, that design and how we'll continue to move forward. Okay, next slide, please. As suggested by the title of this presentation, using the expert panel framework to inform respite research, I'm going to walk us through how the expert panel's findings informed the current project, which is titled Building Evidence for Respite. I'm going to describe some of the methodological, I want to say opportunities and challenges that we've experienced along the way, including COVID-related challenges I'm sure all of us are experiencing. I have some interesting things to say about that. And then we'll present on some emerging themes. As I said, I want to stress that these are preliminary findings, but certainly we are pointing to exactly what we expect to find in this project. And then we'll outline some next steps. Next slide. And again, I so regret missing yesterday. I had a full day of activities on campus. But I know, as presented by Ray Kirk yesterday, providing some background on the expert panel report, this figure represents those key 6 areas to establish evidence for effectiveness of respite care for improving the well-being of caregivers and families and communities. And so what you see circled here is the improved research methodologies. Is where we found an opportunity to make a contribution through the current project. Next slide, please. And so here I'm pulling out some of that language if you are following along in the report, and I hope you've all had a chance an opportunity to read the report. This is coming from page 25, improving the approach to respite research. And so if we, again, revisit that definition pulled out of the expert panel report on what is respite, and we talk about respite as being this planned or emergency care that provides a family caregiver some time away from their caregiving responsibilities. And so we think about how, what I have underlined here, really thinking about respite as a family caregiver intervention. And so as such, the caregiver should be the primary focus or portal of entry for any respite related research. And so this is one area that we pointed to in conceptualizing this study. And then on the next slide, you'll see that also highlighted in the report is this appreciation for how qualitative methods can even capture some of the important contextual information that can be maybe missed or overlooked, and incorporating these methods. For example, if we were thinking about intervention research, for example, an intervention study, how it could help explain sort of some of what's listed here, right? Some cultural differences, or maybe study site differences, or maybe was fidelity achieved or not achieved. Now, in our case, I want to be clear, in our case, we are employing a cross-sectional design, but we still do recognize the benefit or the contribution of qualitative methods for triangulation in particular. And so we use multiple methods, and as you know, triangulation, that's the use of multiple methods to develop a comprehensive understanding of a phenomenon. That's taken from the patent 1999 definition, enhancing the quality and credibility of qualitative research. Next slide, please. And so here's some background information, that I'm sure we've all seen before, and particularly you've probably covered in day one, but I'm just briefly summarizing what's some of the background information highlighted in the report that led us to the current project. And again, this is a cross-sectional study, so not really looking at outcomes, but still this background information provides some important context for this study's aims. Next slide, please. Thank you. So I have to say, as an you saw the associate professor on my title. Just know that that just happened. I'm still very much early career, and I have to tell you, as an early career researcher, it was really exciting to read the report on the heels of finishing up my own pilot respite intervention that I was eager to scale. And so we came together as a team and really talked through and worked through, and think through what could be a meaningful contribution that highlights the findings in the expert panel report. Obviously, we can't do anything, but where could we make a contribution, but also complement the work that I had just completed, building on that expertise as well. And so because of ARCH's relationship with, well, first of all, with the New York State Office on Aging, I see a couple of names on the call today. Oh, I just so much gratitude in how they've contributed to recruitment, but also helping us think through the aims of the project. I'm so thankful. And the Lifespan Respite Partners as well. Excuse me, and the Lifespan Respite Partners as well. We targeted an opportunity to survey caregivers to ask about the dose of respite that they've been receiving through some of what's happening in New York. And then we got to thinking about, okay, so how does that respite relate to burden and well-being and quality of life, as well as understanding the relationship of some of those contextual factors to caregivers' access and desire for respite. And when we talk about contextual factors, we're talking about things like environment, cultural factors, maybe even social networks. And so pulling those things out in this current study. In the report, I want to be clear. So in the report, when we talk about identification of the minimum respite dose, it said that it would lead to a better understanding of the long-term benefits of respite. So I do understand that typically when we're referring to dose, it's usually associated, right, with intervention research, and so how much of an intervention had been received. But for this study, we, how can we operationalize dose in a cross-sectional study? And so for this study, we operationalize respite by asking about frequency, asking about duration, and asking about intensity of respite with the caregivers. And I'm going to show you this in a few minutes, this matrix table that we came up with that I think is really exciting. But as an early career researcher, it doesn't take much to excite me when it comes to this work. And so we spent a lot of time on working through that. And I'm talking about the consultants and other members of my lab. And so for the design here is mixed methods. We have a combination of telephone interviews with caregivers who currently use or recently used in the past 3 months of the time of the eligibility screening call, respite services. And I'll tell you, those telephone interviews take about an hour and a half. It's a lot to get through. And then a subset of those folks are invited to participate in a focus group. So we have both the telephone interviews and we have the focus groups. All right, next slide, please. And so with aim 1 in mind, the measures embedded in this study include some of the typical measures that you might see, including burden, using the Xeric burden interview, the caregiver reaction scale. Particularly, we spent a lot of time talking about how do we capture family level well-being. And I was so surprised to see limited measures on family level well-being. We're using the family conflict subscales as a proxy for family level well-being. And we think that has been a good proxy for measuring that. In addition to what you see here, also the health distress scale, self-rated health, satisfaction with life scale, and also capturing some information about the care recipient, including quality of life, as quality of life for the care recipient. Excuse me. So this is, as I said, a lengthy telephone survey with the caregivers. Even though we have the focus group component, we're still asking some open-ended questions, even in the telephone survey. So for example, a couple that we have are, what made you decide to use respite in the first place? And again, getting at some of that motivation for access to respite. And then describe how respite has helped you in your caregiving role. So thinking about what are some of the benefits of respite, which you see again, language about that in the report. And in addition to what we see here, we're also very interested in caregiver factors such as sleep. So on an average night, how much sleep are you getting? We're asking about chronic conditions. We're asking about physical activities so that we can really create a caregiver profile for those who are in our study. Okay, next slide, please. So, some of the qualitative questions, what services do you consider? And by the way, these aren't the full questions. If anyone is interested in seeing that full lengthy semi-structured interview guide, I'm happy to send it to you. But these are just some that I pulled out so that you can see how we're thinking about that aim to examine some of the contextual factors that contribute to, caregivers' access to and desire for respite. These are questions that are asked in the focus group. And again, please email me. I'm certainly happy to share the full interview guide. And in true qualitative methods, this is iterative, right? We are constantly looking at the data to see how we might need to revise the questions and so forth. Next slide, please. All right, good. So here is the poll question for today. In recruiting for our study, where we've experienced some challenges relate to recruitment. And again, I'm so grateful for the folks at the Health Foundation because, it's been very easy to have very open conversations about, here are some of the recruitment challenges that we've been experiencing. And that's why we're into a third year. We were able to get a no-cost extension because we want to do this right and we want to do this well. And so it gave us time to go back to the drawing board to think about, okay, what does the literature tell us about overcoming some of the recruitment challenges? And this is documented in the literature, right? The recruitment challenges in caregiver research. So even with following the most promising recommendations, we know that there still could be challenges. Just as to let you know, the eligibility criteria here, 18 and older, residing in one of the 16 counties in Western and Central New York, and having used respite currently or within the past 3 months. And I'll just add when I said, COVID-related challenges. So if we think about the eligibility criteria in the past 3 months, well, a lot of caregivers have not used respite services in the past 3 months because of COVID. In fact, here in Athens, Georgia, one of the primary providers of respite services through Adult Day Health has not offered any respite services since the beginning of March. And so I think from a methodological standpoint, we have to rethink how revising that component of the eligibility criteria could affect, potentially our findings. So let's have at it with the polling question. What are some of the recruitment challenges you've encountered in caregiving research? And I don't know if we have the responses here or not, but I can read some that I have listed, I pulled out of the literature. Limited funding for participant incentives, maybe high advertisement costs. Very important, and it sounds like this came up yesterday, lack of culturally tailored strategies, limited geographic scope, maybe miscommunication with partnering agencies or stakeholders or other organizations or some others. And so I see some stuff here coming up here in the chat box that I'm curious to look at, but I'm scared if I pull that up, I'll mess up my whole
Dr. Washington, I just want to let you know that people are still posting on the poll and we'll share the results and they'll go on screen. I know you didn't get to see that yesterday. So.
Okay, that's wonderful. Should I just keep on going and you'll share the results?
No, I think later? It looks like a majority shared. So maybe, Marsha, if you want to end that poll, we can share the results so then everyone can see.
Sure.
There you go. You should be able to see it. Are you seeing it?
I'm sorry, I'm not. Oh, here we go. Found it.
Great.
Posted sharing poll results. Here we go. limited funding for participants and lack of culturally tailored strategies at the top too. Wow. And I noticed some of the others were, I saw IRB, and then I missed some of the other categories, but I would love to see what those are. The limited geographic scope, and just sometimes miscommunication with the partnering agency. Yes, the high advertisement costs, not so much, but I am going to share with you what happened with us in advertising for the study. So, I mean, it's nice to know that I'm in, kind of shared company here, and that this experience is pervasive. But I talk to my students all the time, and I say, it's up to us as researchers. When we talk about so-called hard to reach, that's a term that kind of makes me cringe, because it's like the expectation is that they should come to us, and that's really not the case. And as a social worker, I'm always thinking about reach. How do we meet the people where they are? And so we spent a lot of time thinking through our recruitment strategy. So next slide, and I'll get to that. And I am watching the time. So here's some of what has happened for us in terms of recruitment strategies. And let me take myself to the next slide here. So we employed a number of strategies that are listed here. First, we sent recruitment letters to respite providers throughout the state of New York. These letters were forwarded to providers via the New York State Office on Aging. And again, I see some of them on here today. I'm so grateful to you. They also allowed us to do mini presentations on their monthly Caregiver Network conference calls, which definitely yielded some good numbers, but not quite where we wanted to be, because I'll tell you, what we hoped was going to be the most profitable recruitment effort was last year at the Arch National Lifespan Respite Conference. We added, which Jill or Ray, I'm not sure exactly whose idea it was, but it was a great idea to add to the registration, a little comment about the study. If you are interested in participating, someone will follow up with you. And so we did have a few, and in fact, we did do 2 focus groups at that conference last year, but not quite with the sample size that we want to be at just yet. We're getting there, but not just yet. So at that point, we're thinking, okay, it's definitely time for us to rethink recruitment strategies. We made cold calls to social service providers or agencies that are what we call kind of respite adjacent in New York. In fact, one of my graduate research assistants worked in that network for a number of years, and she was able to call some agencies and just asking, hey, would you consider posting or sending around our ad, our flyer. We've also social media ads, and so I wonder how many of you have used things like Facebook and that sort of thing, but we ran a 4-week Facebook ad. And what's interesting about Facebook, I mean, everyone's using social media, especially in the time of COVID. And what was interesting about Facebook, it really helps you target this specific geographic area where you want ads to pop up. And so we ran that ad for about 4 weeks. I'm a member of the Hartford family, and I call on my Hartford family when I need to. So kind of knocking on doors and asking, I have one colleague who has connections with social workers in New York, and so was able to spread the recruitment flyer around through her network. And again, it's just part of being a part of that wonderful Hartford family. I've been able to, I'll save one last recruitment strategy that we've used in just a moment, and you'll see why when we talk about diversity in the sample. So let me save that comment for later. If you can go on to the next slide. So I know this might be a little bit difficult to read, but I was determined to get this table up so that you can take a look at how we are operationalizing dose when we think about the frequency, intensity, duration. And so let me explain what you're seeing here. This is so if you look at the top left corner, it says in the past 3 months, did you use? So all the way down the y-axis, and this is not the exhausted list. We have a full list. It's just what you see here on this slide. we went into the literature and we thought, what are the many different areas or avenues through which caregivers can access respite services: adult day health, residential care, community agencies, home-based, veterans respite services, hospice, so forth and so on. And so we exhausted that list, and we spent, again, shout out to the consultants who vetted this multiple times. And so what you see across the x-axis in the top is here's where we're getting to, again, some of those things related to intensity and frequency. And you can look at some of the questions here if you can't see it. So for example, we're asking about what type of care needs are provided during the respite, right? Meals and snacks, toileting, showering and bathing, that sort of thing. And they're getting detailed about what that looks like. The costs, who's providing it? Is it a family member? Is it a community who wants this can be? And I'll tell you again, what's been so exciting about this is when we finish an interview, we kind of put that up and we take a look back and we see all of these boxes filled in, and we think to ourselves, wow, this really speaks to the complexity of the use of respite by caregivers. It really captures just how complex and nuanced this can be, how when one source kind of dries up, so to speak, moving along to another source and kind of floating around and finding sources for respite in the community in a variety of different ways. And so we look at this chart and we think this is such an amazing picture of what it means to be a caregiver and navigate the landscape of respite services. Next slide, please. So here's just literally just a snapshot truly of the sample, but it's for illustrative purposes, just to show you, I'm sure one thing that's jumping out to you is the limited diversity. So as I said, this project is ongoing, but we're seeing some of what we might think about in terms of a typical caregiver. Age 63 is about the average age, 62, 63, primarily caregiving for a spouse or parent. At least 2 chronic conditions minimum by the caregiver in our sample. Some great work thinking about how caregivers can map out their own self-care plans, which is something I'm interested in too. But this surprising is sometimes a little bit jarring to see. And because these caregivers are working, you know, we immediately think about, you know, how important respite services can be to working caregivers. Just as an aside, for those of you who are attending the virtual Gerontological Society of America conference this fall, I'm actually chairing a symposium on the challenges experienced by working caregivers. And so it's likely that when we're looking at the analysis for this study, we're going to pull out just the sample of working caregivers to be able to paint a picture of what the use of respite services has been like for them. Next slide. And I'm looking at my time. I'm going to run through these as quickly as possible, pulling out some of the benefits. We saw this, again, this is in the expert panel report. We are extrapolating emergency themes, but again, I say these are just very preliminary themes from our open codes. We're still working through the analysis, but we see here benefits of respite such as freedom. So being able to find rest, being able to leave my house without being stuck at home, and that sort of thing. And okay, thank you, Kim's let me know I have 10 minutes. And to not be on the call, to not have to worry about someone who's going to call me or fix something. You know, we'll see that in the next slide as well, more about freedom. This person just saying, you can go into the next slide. This person just, you know, really talking about how the home care, having a home care aide who's starting to become familiar with the routine and how it allows for some freedom. Next slide, please. Another theme that we're seeing is flexibility. Again, no surprises here. I have flexibility. One staff in particular, she works almost any hours. So if I want to get away, especially if it's overnight, I know that can happen. This is what it's like. Yes, this is what makes respite accessible, having services that can even be offered overnight when I may want to go out of town or something like that. Next slide, please. We're seeing also, you know, what are some barriers to respite costs? Again, that if this person says, and then the cost is impossible for me to pay, even though it's a small amount, it's impossible for me to pay. And they said, these are the providers, don't worry, we're going to give you some help. We're going to give your husband a scholarship. So they did this 3 times a day. Council on Aging saying, called and said they can offer up to 5 free days of respite care. And so that's why, you know, we were being somewhat intentional with choosing the having used respite in the past 3 months, because we know that it can be sporadic or intermittent depending on the services that are provided in various communities. Next slide, please. You heard me say earlier in our aims, thinking about things that relate to motivation. The burden relates to motivation, you know, feelings of being exhausted, feelings of being burnout, and feelings of just getting to the point where I really, really need to take a break. Next slide, please. Well, cultural factors is something that I'm really interested in, and these contextual factors, cultural factors, again, just referring back to the report, is something that I think we don't know enough of, and I would really like for the findings in this study to really point us to, and we're coding the data looking for some of these cultural factors that, again, relate to access to motivation to use respite. My father's an Italian American, first generation, and she talked about how, you know, it was just this expectation that we would care for him. And she went on to say, you know, but we are actually now starting to have conversations about how culturally this is also a way of caring for you, to be able to take some time to access respite care so that we can take a break. Next slide, please. Also thinking about contextual factors, the nature of the social support or social networks. My daughter stayed with him when I got back. She was ready to go. She was like, I can't do this. And so she can only do it for 4 hours. And so this person went on to say, you know, how having to access some more formal services, because sometimes the social network can help, and sometimes it can, and not really a hindrance, but, you know, there are challenges there, and relying on maybe members of a family network to provide these respite services. The focus groups were so great. The focus groups really do give, you get to pull out information that you may not be able to pull out otherwise. Okay, next slide. So in terms of analysis, we'll be examining, of course, relationships in AIM 1. We're going to be doing some thematic analysis for AIM 2, guided by the research aims. That's very important. The thematic analysis will very much map onto the research aims. And so we're just in the open coding phases, and we do have multiple coders, and we'll continue until we reach saturation. Contextual factors are underlined here because we really want to bring forth those contextual factors as they relate to respite. You know, I'm thinking about the conversations that we had early on as we were designing this study, and I think that's something that we all were really motivated and excited about, is thinking about those contextual factors. Next slide. So, limitations. With regard to limitations, it's important to acknowledge, you know, the methodological issues outlined in the expert panel report and how these issues may limit generalizability. We recognize that, you know, sometimes refer to the gold standard as being the randomized controlled trials, but as pointed out in the report, you know, their premature use may result in the loss of good ideas or good programs. And so here, while we do recognize the limitations of cross-sectional data, we also agree that it is appropriate where this design that we have conceptualized is appropriate given the research aim. So letting the question guide the methodology, so to speak. And unfortunately, another challenge that we are experiencing relates to diversity in the sample. The counties from which we are sampling range from a 77% to 96% predominantly white population. Most are kind of actually closer to 90%, falling in the middle. And so as recently noted, actually by Parker and Fabius in the Journal Aging and Health. This was just last month. This just came out. The study Racial Differences in Respite Use Among Black and White Caregivers. And this was looking at caregivers of individuals living with dementia. And they found that, Black dementia caregivers use respite less frequently than their white counterparts. So if we are talking about identifying factors that promote respite use, doing so among, say, Black caregivers, for example, also is particularly important and timely. So I told you I would come back to a recruitment strategy related to diversity. One of the things that I've done, and I'm just, again, so grateful for the Hartford family, is I kind of knocked on the door of a colleague who's at a university in upstate New York, and she is connected to a network of some work that she's done in Black churches. And so that is, and we know from the literature, that is could be one entry point in accessing caregivers, giving them an opportunity to participate in the study. And so hoping that that's also going to yield some, some diversity in the sample. And finally, as I spoke earlier, we've had the recruitment challenges. So the sample size is, but we can get there. Right now, we're not quite there. We're about, a third of the way, but we can get there if we continue to be aggressive with these recruitment strategies that we thought through. And then next slide, please. Okay, so in terms of next steps, so again, my default setting tends to be my social work training sometimes, because I'm always thinking about how do we create accessible and culturally tailored respite services to reach more people. And so it's my hope that the findings from this study contribute to our understanding of factors that relate to caregivers' access to and desire for respite. And so in doing so, how can this knowledge inform the design of my existing respite intervention or others to begin to examine some of the proximal outcomes and ultimately the distal outcomes that we see listed here. This is just a snapshot from that. I encourage you to refer back to that diagram on page 20 of the report. That kind of maps us through a research agenda for respite care. And that's sort of where I'm thinking about how do we get to next steps. And I am on my last slide, I think. Am I right on time? I hope I'm right on time. Yeah, thank you. So questions, and here's my email address. And I know some of you are also on social media. I too tweet about caregiving stuff on social media, so you can follow me there as well. Okay.
Thank you very much, Tiffany. Very interesting, and a lot to think about and to look forward to as the sample size rises to the necessary level.
We'll get there.
And you can get back to us with the more definitive findings in the future. At this point, I'd like to open up the channel, as it were, for questions or comments from the audience. Attendees, please. We have about, I think, maybe 8 minutes before the handoff for the next session. If anyone has a comment or a question, please pop it in the chat. And I remind Kim for a little assistance here with my aged eyes. I can't read that tiny little chat box, so I need an assist.
You got it, Dr.
that.
Kirk. I can definitely moderate the question. So we have a question from Michael in the chat. It says, I'm sorry if I missed this, but have you explored personal barriers to using respite, not just structural, but examples such as being uncomfortable leaving their family member with someone unfamiliar?
Yes, thank you so much, Michael, for your question. Yes, we have. And if you want to see that full questionnaire, semi-structured interview guide, I can send that to you, where we are getting at that in the focus groups in particular. Thank you.
Great. Another question. How do you use language equity to ensure broad outreach?
Oh, a very good question. As you heard me say, being culturally tailored in our approach, as just even as a methodologist, and thinking through what does that mean to culturally tailor. So if I understand your question, thinking about language and having maybe multiple flyers from multiple groups is something that we've thought a lot about, and we are working on that.
And then we have another question from Cheryl. How is chronic conditions defined, and what purpose is in identifying all in research?
We went to sort of the CDC's definition for chronic conditions, and we extrapolated sort of just looking at, 10 leading causes of death at that point, and the what I call the BRFIS for short, and some of the categories for chronic conditions there. So we pulled those categories from the CDC. And thinking broadly about chronic conditions, so not so much chronic disease, we are very careful to say chronic conditions because we think that's more inclusive. And in particular, thinking about things like depression or other conditions that may not be thought about when we say chronic disease.
Another question from Leanne. Were you able to measure the stress impact of those who felt they had no other option versus who chose to be a caregiver?
Well, it's possible. We can think about that when we get to the analyses and really dig into the data and see what's there. I think I'd be a little bit hesitant on saying what we can and cannot do around that just yet, but certainly our questions and our measures, there's a potential that we can look more into that.
And Leanne also commented after the question, she said, I've read research that shows measurable differences with those who felt they had no other option.
Yeah. Thank you, Leanne.
Any other questions? Again, please feel free to post them in the chat while we're waiting for more questions. There we go. We have one from Susan Summers. You mentioned that focus group members were a subset of the larger population you interviewed. Did you select focus group participants on the basis of some attributes?
No, we did not. We offered the caregivers who participated in the telephone survey an opportunity to participate in the focus groups if, really just if they were motivated to tell more of their story. However, I will say, so my team and I, we meet every week and we talk about, okay, what interviews have we completed this week and what are you finding? And if there's something that really stands out to us, something that we really want to know more about, like again, thinking about triangulation and the use of the benefit of using qualitative methods, then we may target that person, but there were no other attributes that we targeted those folks for.
Great. And a question from Dr. Sabatka. It would be interesting to look at deferred healthcare for caregivers. There's been a lot of interest in deferred healthcare due to COVID-19, and I suspect caregivers are duly challenged to take care of their own preventive health needs during this time.
Dr. Sabatka, I actually have a paper that's under review looking at healthcare utilization of working caregivers. And so what are reasons that they are deferring healthcare? I agree with you. That is something that I would love to know more about. I'm not sure that we'll be able to fully uncover that in this study, but it just so happens that I have a paper under review related to that topic.
Great, Dr. Washington. One more question from Sue Peshin. It seems like a lot of participants are married or have partners. Do you think spouses play a role in encouraging respite care to the caregivers? Do single people feel differently about respite care?
Yeah, to answer that question, I think I can only do so anecdotally at this point. I would say yes and maybe. And also just even from personal experience, my family just went through a personal experience of respite services and spousal care between my grandmother and my grandfather who live with Alzheimer's disease. So I think yes, and I think maybe. So when you say, do single people feel differently about respite care, it's possible. And thank you for bringing that up because that's something we can look at as we continue to analyze these data.
And then we have a question from Lita. Did any caregivers self-report cognitive decline?
Yes. Cognitive decline is one of those categories that we have for this whole list of chronic conditions. We're asking about both the caregiver and the care receiver, by the way, but yes, we have had caregivers who are reporting cognitive decline themselves.
Great. Again, feel free to post questions. Oh, go ahead. Sorry.
Oh, I'm sorry. And if you're wondering, the prompt for that question is, has a doctor ever told you specifically, is the prompt, and then we list these chronic conditions.
Great. Again, we probably have time for 1 or 2 more questions if you want to post those in the chat while we're waiting for more questions to pop up. I do want to just point out in the chat, I did post a couple of resources that might be helpful for recruitment and understanding culturally and linguistically appropriate services that could be looked at. So please take a look at those. I think those would be helpful as we all continue to think about how to increase our diversity of our samples. And then there is an article that was posted in the chat on single mothers and respite care related to children with ASD. Thank you, Tina Taylor, for posting that. And then Jill Kagan asks, I may have missed this, but what have you discovered so far about the dose of respite and its importance? Great question. I was wondering that.
Yeah, and Jill, thank you. Again, we're so excited about this matrix, but we haven't got to the point we're really digging deep into analyzing what this means in relation to the importance of respite, except that we are discovering that it is very complex in a way that I had not thought about it. And when I say complex and how caregivers are navigating the landscape of respite, how they're making choices about what respite services to use, and sometimes what dictates those choices, whether it's related to social networks or costs or geographic limitations of what we're finding. So I can't wait to come back to that question in the future and be able to give you a more definitive response. But would love to hear more thoughts about, please, respite table and maybe what we're missing or what we could be capturing, because we are open to more ideas, perhaps not for this study, but thinking ahead in the future. Thank you, Jill.
So I think that will conclude our question. I'm going to pass this back to Ray to wrap us up. But thank you, Dr. Washington.
Thanks.
Thank you.
Thanks for the assist, Kim. And also, again, thanks to you, Dr. Washington, for sharing this process and the promise that your study holds for us in the future.